Good afternoon, participants. Good afternoon, Ms. Carla. We would like to welcome you on our webinar for today, which is entitled Nutritional Management for ICU Patients. Before we start with our webinar, we would like to kindly remind all our attendees, especially for those who are based in UAE. At the moment, we have a new rule, a new policy from Department of Health of how you can acquire your CME certificate. This PDF form is also available in our drive. We will share it with you after our webinar for today for your further information. So as you can see, everyone should have an account with DOH. You need to download the UAE Pass, create an account through TAM online using your Emirates ID. All the step-by-step process will be given to you, will be provided on how you can get your certificate. These are all for UAE participants only. For international attendees, we will send your certificate through PDF, through email. Again, attendees, please be reminded that your certificates will only be available through the TAM portal of Department of Health. So once again, everyone, we would like to welcome you to our webinar for today, which will be hosted, and our speaker will be Ms. Carla, who is currently working as a clinical dietitian at Cleveland Clinic, Abu Dhabi, where she has covered different units, including medical and ICUs, and currently works on the surgical unit where she serves patients with diverse diagnosis undergoing different kinds of surgeries, mainly gastrointestinal surgeries. Our course will be entitled Nutritional Management for ICU Patients, which is sponsored by Specialized Beauty on behalf of InBody Machine. Ms. Carla, we would like to welcome you and thank you once again on behalf of TEDKI for giving this opportunity to provide this wonderful topic with our participants. The floor is yours, Ms. Carla.
Hello, everyone. Thank you, Kim. And it's my pleasure to be with you guys tonight. I hope this would be an informative and an interesting session. I want to thank all the participants to have registered and tuned in my session and presentation tonight. I know it's 6 p.m. UAE time, so I hope you guys are not too tired by the end of a probably busy day at work. So I'm gonna try my best not to keep you for too long and to make this presentation as simple, straightforward, and brief as possible. So I'm gonna share my PowerPoint to start with. And just to give you an idea, as Kim mentioned, our topic is gonna be about the nutritional management of the patients with COVID-19 in the ICU. So to start with, we're gonna go over an overview of the presentation's different topics that we're going to discuss tonight. We're going to start with a very brief overview of coronaviruses and mainly the SARS-CoV-2. What is the impact of COVID-19 on different physiological systems? How is nutrition an integral component of the supportive care in the ICU? What are the consequences of the COVID-19 disease? And what are the main guiding principles for the management of COVID-19 disease, and mainly the nutrition recommendations suggested by ASPEN and ESPEN for the nutritional treatment of COVID-19 patients, how to optimize the nutritional management, and what are the challenges that we face when we try to follow the nutritional recommendations. So to start with, this is a very brief and short overview and introduction of COVID-19 and coronavirus. I'm sure we've been all dealing with this pandemic since the end of 2019 after the outbreak that has started in China. So I'm not going to dwell much on the definition or the introduction of it. I'm sure we're all familiar with this, but just as a reminder and a refresher to everyone, coronaviruses is mainly a family of a common virus that can cause an infection in the nose, the sinuses, or the upper throat. So in early 2020, the SARS-CoV-2 was a new type of coronavirus that was identified by the WHO as the new type of this coronavirus, and it was mainly the trigger for the COVID-19 disease, which unfortunately we've been dealing with for 2 years and still actually in this pandemic up until today. So this virus can cause an infection in the respiratory tract. And when we say respiratory tract, that can be the upper or the lower tract. So when we refer to the upper tract, that's mainly including sinuses, the nose, or the throat. And when we refer to the lower tract, that's mainly the trachea or the lungs mainly. And when the infection is a little bit more severe, then this is when the virus has actually invaded the lungs. So in terms of the symptoms, I'm sure that the majority of you either know someone who has tested positive at some point since the beginning of the pandemic, or you might have tested positive yourself. So you are familiar maybe with the symptoms that can include fever or sore throat, if GI symptoms that can include nausea and vomiting, loss of smell and taste, maybe headaches or runny nose and shortness of breath. So the symptoms can be mild and severe, and so is the infection. It can range from mild, and this is the case of so many patients that we know that maybe tested positive for COVID-19 and recovered from the disease only by self-isolation or quarantining at home. And infections can be more severe, and it can become deadly sometimes. And this has been the case in so many patients, unfortunately. So instead of dwelling more on the introduction of the virus itself, I prefer to maybe give more details about the impact of COVID-19 on different physiological systems. So as I mentioned, it does affect the respiratory tract, but not only this, it does have an impact on the GI tract, the neurological system, and the nephrology system, the kidneys basically. So what it does, the virus basically uses the angiotensin converting enzyme 2 receptor that is present in the lymphocytes or the monocytes in the epithelial cells. And what it does, it creates a rapid viral replication and cell damage, which leads to high inflammatory signals and basically inflammation and the cytokine storm. So when the cytokine storm is there, this is when we have an increase in the cytokine plasma levels, which leads to what we know as the ARDS, which is the acute respiratory distress syndrome, the multi-organ system failure, the hyperinflammation syndrome, and in many cases, it leads to death. When a patient has those severe symptoms and infection, this requires, in most of the times, admission to the patient, either to the hospital, acute care, or to ICU. And what we're going to be covering in this presentation tonight is mainly admission to ICU. So before I move on to the importance of nutrition and the role that it plays in managing those patients, an understanding of the metabolic response is really essential in order to understand or to better understand the role that nutrition plays in treating those patients. So to begin with, I'm gonna start with describing the metabolic response. I think if any one of you has attended my previous presentation with Tafkif last year, we did go over the stress response to surgery in details. I'm gonna just go briefly over it here just so to refresh your memory. So the metabolic response as a result of the hyperinflammation syndrome, it includes an activation of the sympathetic nervous system, the endocrine response with the pituitary hormone secretion and insulin resistance, and the immunologic and the hematologic changes. So what happens when the metabolic response is activated, and mainly the sympathetic nervous system, we will have an increase of catecholamines by our adrenal medulla, which are mainly adrenaline or noradrenaline, epinephrine and norepinephrine. And when those are high, this leads to an increase in blood pressure and an increase in heart rate or tachycardia. And on the other hand, we observe an increase in the ACTH, which is the adrenocorticotropic hormone. And when this is high, it leads to an increase in release of cortisol by our adrenal cortex. And why are we focusing here on cortisol? So cortisol has many functions at the level of different organs. And when it's really high, it actually modifies its function at the level of different organs. So for example, at the level of the liver, what it does is that it promotes gluconeogenesis. At the level of the bone, it reduces the bone formation, and it leads to lipolysis, which is the breakdown of fat at the level of adipose tissue. And at the level of the pancreas, what it does is that it counteracts insulin. So what it does is that it leads to an increase in glucagon and increase in the peripheral insulin resistance. And at the level of the muscle, it decreases the uptake of the amino acids by the muscle. So if you notice that all of those changes lead to a decrease in lean body mass and muscle depletion in those patients. So the metabolic response is mainly characterized by 3 phases: the early, late, and post, or what we know as the ebb, the flow phase, and the recovery phase. So basically in the EP phase, this is where there's a lot of hemodynamic changes. And the EP phase usually takes place in the first 24 to 48 hours after exposure to injury, which can be stress or trauma or surgery, or in that case, we're referring to the infection from the ARDS. So in the EP phase, we've got a decreased body temperature, lactic acidosis, an increase in stress hormones, and hyperglycemia and gluconeogenesis. And a couple of days after the injury happens, this is where the body enters the flow phase, which is mainly characterized by catabolism. And this is where we have an increase in body temperature, increase in oxygen consumption, and negative nitrogen balance, which is usually the result of the amino acids being mobilized from predominantly the muscle. We have hyperglycemia and breakdown of the protein, so as the fat or the lipolysis. So those nutritional consequences of the hyperinflammation syndrome, which is mainly catabolism and an increased energy expenditure, when those take place, this requires us as dietitians to increase energy and protein requirements for patients and to early intervene and provide them a nutrition support. And what is particular to COVID-19 specifically is not only the consequences from the hyperinflammation syndrome, but also the food intake of patients with COVID-19 prior to their admission to the hospital is also affected. And it's affected usually by the infection, by them feeling sick, losing their smell and taste, having poor appetite, the stress phase that they're going through. So their food intake is reduced for a couple of days prior to their admission to the hospital. And because there's physical immobilization coming from them feeling tired and sick and not able to ambulate much, and because they're hypermetabolic, this also leads to a rapid muscle wasting. So if you notice that the consequences of the cytokine storm and their food intake reduction and their lack of mobilization, all of those put those patients at risk of malnutrition. So they are pre-exposed to malnutrition prior to admission to the hospital. So before I dig into the nutritional intervention and what is the management of COVID-19 patients, I would like to briefly go over the ICU population and describe this population just to have an idea about how complex and critically ill those patients can be and how ICU population is a little bit different than patients who are admitted to an acute care floor or to a medical surgical floor. So most of the patients in the ICU, whether they're COVID-19 or non-COVID-19 ICU patients, they are characterized by their hemodynamic instability. So we look a lot at the hemodynamic parameters in the ICU. And what I mean by that could be, for example, lactate levels, their MAP, their mean arterial pressure can be very low. Their lactate levels can be high, their heart rate can be really high as well. And those patients are usually on multiple vasopressors. And the reason they're on vasopressors is to help them increase or stabilize their mean arterial pressure. So for example, we have norepinephrine or epinephrine, those are mainly they lead to a vasoconstriction. We've got some inotropes such as dobutamine or dopamine, which can also lead to an increase in cardiac contractility. So those patients are on multiple vasopressors. They might be unstable. They often require organ support. And this can be in the form of a ventilator or they can be on ECMO. And for those of you maybe who are not very familiar with ECMO, this is just, it stands for the extracorporeal membrane oxygenation. And what it does basically, it's very similar to a heart-lung bypass machine. So what it does is that it pumps and oxygenates a patient's blood outside their body, leaving their lungs and their hearts to rest. And when a patient is connected to ECMO, the blood usually flows through tubing to an artificial lung, which is in the machine. What it does is that it adds oxygen to the blood and it takes away the carbon dioxide, the CO2, and then the blood is warmed to the body temperature and pumped back into the patient's body. And in the ICU, we tend to see patients on two different kinds of ECMO. Those include VA ECMO or VV ECMO. So VA ECMO is when it's connected to both the vein and the artery. And this is usually used when the patient has a problem with the heart and the lung. As opposed to the VV ECMO, this is when it's connected to one or more vein, usually near the heart, but this is when the problem only relies in the lung. They can also require other kind of organ support, which is the CRRT or the IHT, which is basically dialysis. So the CRRT, which stands for the continuous renal replacement therapy, this is a special type of dialysis that is done for patients in the ICU who are not really stable and whose bodies cannot tolerate the regular hemodialysis that we all know it can be done as an outpatient procedure. It is usually done 3 to 4 hours or 3 to 4 times a week, depending on the patient's medical condition. So usually the flow rate to remove the waste in the fluid by hemodialysis from the patients are generally really fast, that ICU patient and ICU unstable patient mainly cannot tolerate it because it puts their heart and their blood pressure under stress. So this is why we usually put them on CRRT, which is always performed over 24 hours. So this is just to show you that those patients in the ICU require a lot of different organ support and a lot of management and close monitoring. On top of this, they are presented usually with sepsis. And as I mentioned, they can be hemodynamic unstable, and they require many medications for sedation. So they are on sedative agents most of the times. Those can be short acting, such as Propofol, or on any benzodiazepine, such as midazolam or lorazepam, which we see a lot in the ICU, or maybe on some opioid medications, such as fentanyl and remifentanil. And when patients are sedated, that makes them unconscious and not oriented. So this limits the communication of healthcare providers with the patient. So I just wanted to describe this population briefly, just to have an idea about the complexity of the cases that we can see in ICU. So that being said, it is obvious for us now that the assessment, nutritional assessment of those patients prior to upon their admission is really essential, and the nutritional care management must be integrated into the overall supportive therapeutic strategy of those patients, just like we do in any other illness. And since nutrition started taking role in the healthcare field, it was regarded as an adjunctive care that is designed to provide exogenous fuels to preserve the lean body mass and to prevent the oxidative cellular injury and to modulate some immune responses and to help support the patient throughout the stress response, hence its importance in the management of COVID-19 patients. So to be honest, the management of a patient with COVID-19 admitted to the ICU is very, very similar to how we nutritionally manage a non-COVID-19 ICU patient. But the main factors that we take into account with a COVID-19 patient, and those factors are actually being emphasized on in most of the recommendations, are cluster care to decrease the contact with patients given the high risk of viral transmission, to minimize the droplet exposure with an emphasis on hand hygiene and utilization of the PPE all the times, and to preserve the use of PPE mainly to nurses, to intensivists, or to respiratory therapists, as this is of high priority when managing a patient with COVID-19. So this slide here focuses on all of the recommendations that Aspen and ESPEN have suggested. We're going to go over each one of them in details as we move forward in the presentation, but just to give you an idea about what to expect moving forward, we're going to be talking about refeeding syndrome and its complications and the role of propofol in refeeding syndrome, malnutrition diagnosis among those patients, and the use of validated tools to diagnose patients with malnutrition, the nutrition support route that we should follow and use with patients with COVID-19, if it's enteral nutrition versus parenteral nutrition, and the best timing to start nutrition support, the role of physical activity, especially after extubation. What do we do in the case of proning? When we prone the patient, what kind of nutrition support we should use? And what is the role of the nutritional support after extubation? And whenever parenteral nutrition is indicated, we should know the proper indications for it. When is it contraindicated? And how do we decide whether a patient needs TPN or not? What's the best way to measure the patient's caloric needs, whether is it indirect calorimetry or something else? And the use of omega-3 fatty acids versus omega-6 fatty acids. So To start with, the first recommendation was about refeeding syndrome and its complications and the role that propofol plays when we are considering refeeding syndrome. So as you all know, refeeding syndrome is mainly characterized by hypokalemia, hypophosphatemia, and hypomagnesemia. And what's specific about COVID-19 patients is that in most of the times, those patients are usually sick and feeling unwell for about a week or 10 days prior to their admission to the ICU, which leads to some energy deficit before their admission. Because as we said, their food intake is usually compromised and decreased prior to admission, which places them at risk of refeeding. But the thing with those patients is that upon admission, if they're intubated and they're not conscious, we cannot really get to communicate with them. And given they are in an enhanced droplet room, their family members are not always there. So we tend to have a very limited information about their diet history. So this is why refeeding syndrome is underestimated among those patients. So it is very important to detect it and to prevent it from happening. And what is recommended is to basically measure the potassium, phosphorus, and the magnesium 6 hours after we start their nutrition support, whatever kind of nutrition support it is, whether it's enteral or parenteral. It is very important to keep a close monitoring of those electrolytes and specifically measure them 6 hours after initiation of the support. So the reason we're talking about propofol here is because propofol is a sedative agent that actually has calories. It has 1.1 calorie per 1 ml of the drug. So many patients with COVID-19, once admitted to the ICU, they are placed on a high dose of propofol, which tends to give them a big amount of calories upon admission. So sometimes if we divide the total number of calories that the patient is provided with propofol, and if we divide it by their weight, they tend to be receiving a lot more than what's recommended in terms of calories per kilogram on day one. So even if no nutrition support is started on day one, it is still important to look at how many calories is the patient getting from propofol and still monitor the electrolytes and replete as needed. The other main thing about propofol, which affects us, from a dietitian's point of view and nutritionally, is the propofol infusion syndrome, which is usually a rare complication that can happen from using propofol, and it must be evoked in case of hemodynamic degradation or lactic acidosis. So what we do is that we tend to measure the plasma lactate, the creatine phosphokinase, and triglycerides. And if we see a trend up of those parameters, this is when we can anticipate the risk of propofol infusion syndrome, and we recommend to stop it, or in most of the cases, use an alternative sedation, maybe more of a long-acting sedative agent, and that would be an essential discussion to have with the intensivist or other doctors in the ICU to make sure we change it to another medication. The other thing about propofol, since it's a soybean lipid-based drug, what it does is that it leads to an increase in triglycerides. So patients with COVID-19, irrespective and independently of being on propofol, because there's this cytokine storm that we spoke about that's happening and taking place, it leads usually to the hemophagocytosis, which increases plasma triglycerides. So patients with COVID-19 tend to have high levels of triglycerides. And because they're on propofol, they can have an increase further of triglycerides, which is essential for us to monitor. And hence also another reason for sometimes changing propofol to another medication. And it is recommended to measure triglyceride levels every 72 hours in all COVID-19 patients in the ICU. Another thing to consider is basically the administration or supplementation of omega-6. I'm not going to dwell on this here much, and we're going to discuss it in further details as we move forward, but just to give you an idea that this is not recommended in the ICU for COVID-19 because of the inflammatory response that they cause, their pro-inflammatory effects, and their immunosuppressive effects. The other recommendation, or the main point to focus on, is malnutrition status or malnutrition diagnosis of patients with COVID-19. So it is essential that they should be considered for malnutrition. However, there is a little bit of a drawback of using malnutrition diagnosis in the ICU. So just to also remind you that there are existing nutritional assessment tools. Only the validated ones should be used to diagnose patients with malnutrition, such as the GLIM, which is the Global Leadership Initiative in Malnutrition, the Nutrition Risk Score, and the Nutrition Risk in Critically Ill, which is the Nutric score. They are all validated tools to use. I'm only going to go over GLIM criteria because this is basically what we use at Cleveland Clinic, and most of the papers now are also moving towards using the GLIM criteria to diagnose a patient with malnutrition. So for those of you who are not familiar with it, I'm just going to explain it briefly to let you know how to diagnose someone with malnutrition. So as you see in this page here, GLIM criteria is divided into two criteria, the phenotypic and the etiologic criteria. So to diagnose a patient with malnutrition, the patient has to take at least one factor of each of the criteria to be able to be diagnosed with malnutrition. So what is phenotypic criteria? It usually focuses on the anthropometrics part of the patient. So it focuses on their weight loss and whether they have a low BMI and whether they have a reduced muscle mass or not. And weight loss history. So for example, we look at whether the patient has more than 10% weight loss within 6 months, or if they have 5 to 10% within 6 months, which puts them at moderate malnutrition. If they've got more than 10% within 6 months, then this would be considered as severe malnutrition. When we look at BMI, low BMI is a very general and broad term, but specifically what we look at, if the BMI is less than 18.5 for someone who's below 70 years, then this is considered as a ticked criteria under phenotypic, or if it's less than 20 kilogram per meter square for someone who is above 70 years old. And reduced muscle mass is also another factor to consider under phenotypic criteria. Moving on to the etiologic criteria, that includes the inflammation. So if a patient has any acute or chronic disease that can cause inflammation. And it also includes their diet history, which can show sometimes a reduction in food intake. So if a patient has less than 50% of needs over more than 2 weeks, or managing only 50% for 1 week prior to admission, then this is considered a factor of the etiologic criteria. And it also includes a GI condition that can lead to malabsorption of food sometimes, which is also considered a factor of etiologic criteria. So if you notice, that being said, all the patients with COVID-19 definitely tick the etiologic criteria because they all have COVID-19, so which is considered an acute disease which causes inflammation. So they definitely have this factor under the etiologic criteria ticked. However, as I mentioned, for them to be malnourished, they have to tick another factor of the phenotypic criteria, which in so many times, especially with this specific population, is the phenotypic criteria are poorly applicable. And we're going to know why in a second. So if you look at this slide here, the phenotypic criteria usually, as I said, focuses on the anthropometrics part. So if we have a patient admitted and we want to measure their weight machine and the high chart are difficult to use among those patients because if they're intubated, then they're not conscious, they're not oriented, they're not awake, they can't stand up to be measured. So we tend to use the ICU beds, especially the ones that have an integrated weight system. This is okay to use, but it sometimes reflects an inaccurate weight because especially if we have fluid shifts, so we're not able to get an accurate weight of the patient. And if the patient is not awake or oriented, then we cannot ask the patient about their weight history, whether they've lost weight or not. So we will not have any idea about their history. Also, another factor, this one here, the reduced muscle mass. So we usually diagnose or tick this factor by conducting NFPE, which is the nutrition-focused physical examination. But because of the enhanced airborne isolation and the need to preserve the PPE, NFPE is not conducted among those patients. So we're not able to tell whether they've got a muscle deficit or not. But ideally, the bioelectrical impedance analysis and the measurement of the muscle strength by the hand grip dynamometry are excellent ways and accurate ways of measuring this deficit or not. However, this is only applicable in among those patients if the equipment is sterile and safe to use, and especially decontaminated after each use, which sometimes can be a little bit challenging in the ICU. So the phenotypic criteria is not applicable most of the times. However, the etiologic criteria is always there, especially because the inflammation part is ticked. But having one criteria there and not the other one leads to most of the times underdiagnosing of malnutrition in the ICU. And again, with not having family members and having the patient in enhanced droplet, intubated, not conscious, and not having a proper weight and diet history assessment, we cannot diagnose malnutrition all the time in the ICU. So moving on to the third recommendation, it is about indirect calorimetry. So as per Aspen and ESPEN, this should be used only for patients staying for more than 10 days or those on full parenteral nutrition. And the main reason for that is to avoid overfeeding. So we all know that the indirect calorimetry is usually the gold standard method to assess the energy requirements for most of the patients who are non-COVID-19. However, this remains controversial when trying to apply applying this on COVID-19 patients. So I just wanted to show you what Aspen and the Australian guidelines and the European guidelines recommended in terms of indirect calorimetry. So Aspen mentions that while the energy requirements can ideally be determined by indirect calorimetry, the principle of clustering of care is important and recommends instead using the weight-based equations to estimate the energy requirements instead of using the indirect calorimetry. The Australian guidelines do not recommend the use of indirect calorimetry in COVID-19 patients. However, the European guidelines mention that indirect calorimetry can be used only if safely available with ensured sterility of the measurement system. And if this is not possible, then it's also better to use the weight-based equation to estimate the requirements. However, the reason they recommend indirect calorimetry, especially after 10 days of admission, is to prevent overfeeding. We tend to see a lot of underfeeding and overfeeding in the ICU. Underfeeding is common in obese patients. So usually obese patients, they have increased energy expenditure as compared to non-obese, and this leads to delay in initiation of nutritional support among those patients. The obesity or obese patients they have more of protein catabolism. So it is very important to avoid restrictive and hypocaloric nutrition among those patients. We see a lot of rapid weight loss. So if you guys remember, we mentioned the cytokine storm, which leads to a severe muscle deficit. And so besides the consequence of the hyperinflammation syndrome, because sometimes you're underfed, they would also lose more weight. So it's important for us to compensate for this loss by providing higher energy and higher protein nutrition provision. And patients on parenteral nutrition are the most at risk of developing complications that are related to overfeeding, and this includes hyperglycemia or high blood sugar levels, high triglyceride levels, bacteremia, and liver injury. So this is one of the main recommendations that interests, especially as dietitians, is basically enteral nutrition. And when should we start enteral nutrition, and what are the factors to consider when a patient is on tube feeding? So there has been a lack of consensus among different guidelines, Aspen and ESPEN mainly, about the best timing to start nutrition support after admission. And I think the main reason it's not a consistent consensus among all of them is the heterogeneity of the ICU patients. And what I mean by that is maybe different gender, different age range, or maybe different comorbidities as past medical history. So American guidelines recommend to start the enteral nutrition feeding within less than 48 hours of the ICU admission, as opposed to ESPEN, which recommends it 24 to 36 hours or 12 hours after intubation. But if we notice that the end result of both of those recommendations is to basically start the enteral nutrition within less than 48 hours after ICU admission, and to progressively increase the rate of the nutrition support or the volume of the feed, to reach the target by day 4 to 6, which is mainly the first week of ICU admission. And to be very specific about this, Aspen recommends meeting 80% of the needs within the first 48 hours, as opposed to Aspen recommends meeting 70% of the needs over 3 to 7 days. So basically over the first week of ICU admission. And in terms of which formula to use in terms of tube feeding, just like any other ICU patient, it is recommended to use polymeric standard enteral feeding formula, and definitely to monitor tolerance of the patient. If there is any GI concern or patient is not tolerating a polymeric formula, this is when we can consider shifting it to a semi-elemental as a second line or an alternative to the polymeric. A specific thing to consider among the COVID-19 patients is the prone positioning. So also for those of you who are not familiar with it, what happens is the SARS-CoV-2, it leads to the ARDS, the acute respiratory distress syndrome, which all the times require an invasive mechanical ventilation. And despite these measures, some of the ARDS patients do develop refractory hypoxemia. And it has been shown that proning the patient, so putting them, face down, is a very, it's an easy and inexpensive technique that helps improve the oxygenation and increases the bronchial secretion clearance. And this has been associated with a decreased ventilator-induced lung injury and an increased survival rate in patients with ARDS and mainly refractory hypoxemia. So we tend to see a lot of the COVID-19 patients put in a prone position. And maybe many of you wonder whether tube feeding is still recommended in a prone position, and if yes, what kind of tube should be used in that position. So it hasn't been shown that nasogastric tube feeding specifically is contraindicated in prone position. So even if patient is intubated and connected to so many different machines and placed in prone position, it is still recommended to give enteral feeding. It has not been associated with gastroparesis or vomiting, nor with large gastric residual volume. However, even though those are the recommendations, I suggest to monitor the tolerance of the feed while patient is in prone position. Sometimes it does happen that we see them having maybe vomiting or intolerance to feed, but that doesn't mean that they shouldn't be on tube feeding. It's just a matter of maybe stopping the feeds temporarily and then reassess and restart the feed. Also, some of the COVID-19 patients are admitted with a history of diarrhea or GI concern or some abdominal pain or vomiting. But even if they have this as a history, there is no contraindication to start them on tube feeding. However, as I said, it's just a matter of monitoring. If they have intolerance to the feeds, what we do is we temporarily stop it or reduce the volume if they were already on a high volume. And then we measure, and then we wait for a couple of hours and we resume the tube feeding if the GI symptoms are relieved. However, if they're still there, we can switch to PPN depending on the expected time of the patient being on nutrition support. And if the patient is able to tolerate, for example, 20 ml and not 40 ml per hour of a tube feed, we can keep them on 20 ml running plus supplement with PPN. Or in worst cases, we can switch to TPN if patient is completely not tolerating the enteral feed. Also, another thing to consider when the patient is on tube feeding, especially the COVID-19 patient, as we spoke earlier when I described the ICU population, is basically the hemodynamic instability of the patient. So if patient is hemodynamically unstable, the enteral feeding should be withheld. And we should only reinitiate it only when they are on a stable dose of vasopressor support. So if a patient is on multiple catecholamines or on multiple vasopressors, on norepinephrine, epinephrine, and phenylephrine, for example, or dobutamine, we should consider stopping the enteral feed, because this means that the patient is hemodynamically unstable and requiring a high dose of vasopressors. If their MAP is less than 50 or they've got increased lactate levels, it is also recommended to hold enteral feeds until patient is more stable, and this is when we can reinitiate it. So we have to adequately resuscitate the patient first, And after we're sure that patient has been on stable vasopressor for a while and maintaining a mean arterial pressure or MAP of more than 65, this is when we can reinitiate or restart the enteral feed. So because the ICU patient is it's a complex case and they're actually critically ill, there are also a lot of factors to consider when they are on tube feeding. So for example, we should pay attention to whether the patient has fluid overload or not, whether they have pulmonary edema, renal or cardiac failure. But why is that? So working closely with the intensivist, if a patient needs to be on a fluid restriction, then it's essential to have a discussion with the doctor to make sure what is the volume, target volume per day that the patient should be on. And this allows us to choose our feeding formula better. So it is always safe to go with a semi-concentrated or a more concentrated feeding formula, and basically a 1.5 to 2 kcal per ml feeding formula in order to be able to provide the patient with their nutritional needs with a lower volume. The other factor to consider is the regimen type. And what I mean by that is whether to provide the patient with continuous or bolus feeding. So it has been recommended to use continuous feeding among those patients, given the high risk of aspiration, but not only that. So focusing on the idea of cluster care and limiting interaction with the patient, it is better to go with continuous as opposed to bolus, because if putting a patient on a bolus feed, that requires that the nurse goes in several times a day to give the feeding bottle to the patient. So we would want to limit this interaction with the patient and preserve the PPE. So it is better to go with continuous. And from a clinical perspective, it has been shown in many meta-analyses that when providing a patient with continuous feeding, there has been a reduction in diarrhea and a better control of blood sugar levels when providing patients with continuous over bolus. However, no other differences have been shown in different studies. Also, a third factor is the GI concern, and mainly GRV. So I've mentioned GI concern several times, but I did not mention whether this is diarrhea or vomiting or aspiration or gastric residual volume. So we tend to see in so many hospitals and so many ICU floors still measuring the gastric residual volume. However, it is not recommended to check for GRV, and that's because it is not reliable for detection of delayed gastric emptying. And the risk of aspiration has been shown to be a deterrent to the delivery of enteral nutrition and should not be utilized as a monitor to feeding tolerance. However, despite this recommendation and the study's findings, some hospitals or ICU floors still check GRV. And in case you work at a place where they still do that, and if GRV was between 250 to 500 ml, without the patient having any other gastrointestinal symptoms such as vomiting or diarrhea, it is still not recommended to hold the feeds. However, what we can do to avoid this from happening or to resolve it is to suggest prokinetic agents such as metoclopramide or erythromycin to help with the gastric emptying. Also, if there's diarrhea, the first line of intervention would not be changing the feeding formula from polymeric to a semi-elemental formula, for example, or a fiber-free formula. Diarrhea has many etiologies, so it is recommended to check for the etiology first. A patient can have, for example, C. diff or any other infection that causes the diarrhea. So it is better to do some stool culture analysis maybe or C. diff results and check for this first. And if it's the case, that can be treated with antibiotics prior to changing the feeding formula. However, if no proper etiology is there, then it would be just logical to try and change feeding formula to a semi-elemental or basically a fiber-free formula. Another thing to consider is the nasogastric versus nasojejunal tube or the post-pyloric feeding and when to place the tube. So to minimize the breach of the airborne isolation and to limit exposure to the healthcare providers, patients who require a post-pyloric tube should undergo the bedside placement of this tube with technique that does not require endoscopy or fluoroscopy guidance, just like in normal situation. And that's also to limit the exposure to different, machine and the patient himself. So When it comes to the nasogastric tube, in many cases, it should be placed at bedside and at the same time of intubation. And the X-ray that is usually conducted to confirm the positioning of the tube should be clustered at the same time with the chest X-ray, also to avoid the exposure further. Other factors to consider are usually the organ support that we talked about before, is whether the patient is on ECMO or on CRRT versus hemodialysis. So if the patient is on regular dialysis in the ICU, it is recommended to provide 1.2 to 2 grams per kilograms of protein and up to 2.5 grams per kilogram if a patient is on continuous renal replacement therapy. However, if the patient is on ECMO, it is recommended by ASPEN to provide 20 to 25 calories per kilogram and 25 to 30 calories per kilogram according to the European guidelines. And it's important to not to exceed 30 kcal per kilo for a patient on ECMO. So we covered the enteral nutrition support. However, there's also sometimes some of the patients who require parenteral nutrition, and it is essential for us to understand when to provide the patient with PM. So if the patient is not tolerating enteral nutrition or they have unstable gut, this is when parenteral nutrition is indicated. It is prescribed using a case-by-case, especially after discussing it with the intensivist in the ICU. If a patient is on parenteral nutrition, it is very important to monitor their liver function and mainly also the blood sugar levels and the electrolytes, and there's the overfeeding concerns that we spoke about earlier to take into account. So as we described the time of initiation and how to give enteral nutrition to COVID-19 patients, there are also some recommendations particular to parenteral nutrition. So if the patient is diagnosed with severe malnutrition and they've got intolerance to enteral feeding, it is recommended to start parenteral nutrition as early as possible after their ICU admission. If the patient is able to tolerate enteral feeding, but not able to meet more than 60% of the nutritional needs through the enteral route only, then this is when supplemental parenteral nutrition is recommended, and that can be in the form of PPN, which is peripheral parenteral nutrition, or the central parenteral nutrition. What's very important to consider when parenteral nutrition is started is care should be taken to reduce the risk from hyperglycemia, to monitor for the liver function, for electrolyte imbalances, and for immune suppression and increased oxidative stress. So it requires close monitoring to patients when on PM. In terms of numerical requirements, it is recommended to provide the patient with hypocaloric parenteral nutrition, which is less than 20 kcal per kilogram per day, or only 80% of the needs of the patient, plus 1.2 or higher gram per kilogram per day of proteins, and that should be delivered for patients who are severely malnourished over the first week of ICU admission. So this figure here kind of summarizes only the enteral and the parenteral nutritional part, or the main nutrition management of COVID-19 patients. So if you remember, we talked about refeeding syndrome. So it is important to prevent it and to assess for refeeding syndrome and to replete electrolytes as nutrition support is started. The first line of treatment would be enteral nutrition. It should be started within less than 48 hours after ICU admission, using the nasogastric tube first. If not tolerated or risk of aspiration, this is when we can shift to nasojejunal. Even if the patient is in prone positioning, and nasogastric is recommended. However, if enteral nutrition is not possible or contraindicated, or the gut is unstable, this is when parenteral nutrition should be prescribed. It is only recommended to give supplemental PN if the patient is not meeting more than 60% and not before day 4. And if patient is on parenteral nutrition, it is important to always provide the patient with multivitamins and trace elements as well. This small table over here just shows us the energy and the protein requirements, which is mainly target is 25 kcal per kilo of calories and a minimum of 1.2 or 1.3 gram per kilogram of proteins. They kind of divided this into giving 10 kcal per kilogram per day on day 1, increase to 15 on day 2, 20 kcal on day 3 up until reaching 25 kcal per kilogram on day 4. And if you notice that day 4 is kind of the mid of the first week of ICU admission, so we tend to meet our requirements by then. The omega-3 fatty acids part is going to be discussed separately in the next slides. So you might be wondering about whether to provide the patient with omega-3 fatty acids versus omega-6, and what about the fish oil role and the fish oil enriched intravenous fat emulsions, whether it is recommended or not when a patient is on parenteral nutrition. So traditionally, soybean oil used to be given to patients, especially on PN, because they're actually high in long-chain fatty acids, omega-6 polyunsaturated fatty acids, but those have been shown to have pro-inflammatory and immunosuppressive effects. So over years, it has been, recommendations have changed to recommend the fish oil instead of soybean oil, and that's because of their high concentration or content of the omega-3 polyunsaturated fatty acids, which always includes the essential fatty acids, the DHA and the EPA, and those are known to have anti-inflammatory and immunomodulatory effects. So it is definitely safer and better to use the fish oil as opposed to soybean oil. Also, the risk of infection and the ICU length of stay and the hospital overall length of stay and the risk of sepsis have been shown to be decreased when omega-3 fatty acids are supplemented in comparison to only when the intravenous lipid emulsions are provided. However, if only the intravenous lipid emulsion is required, the fish oil enriched lipid emulsion should be prescribed at a dose of 0.1 to 0.2 gram per kilogram per day. There has been a lot of findings and talks about the benefits of the essential fatty acids, the EPA and the DHA, in regards to the length of ventilation and the improving of oxygenation and the ICU length of stay. However, I did not include those as a recommendation or major findings because they were based on low quality studies, and this requires further research and analysis to make sure whether essential fatty acids does have an impact on the ICU length of stay and the length of ventilation. This table here, I'm not going to go in details over every single one of those vitamins or trace elements, but this is just to show you that it is essential to monitor the vitamin levels of the patients with COVID-19 in the ICU, along with their trace elements, as they all contribute to the maintenance of the functional and the structural integrity of the mucosal cells. It shows you the recommended dose for the healthy individuals as opposed to the individuals who are infected with the disease. So this is just a good reference to go back to, just to know the doses of each of the vitamins and trace elements. And it's pretty good to work closely with the pharmacotherapist to also discuss the recommended dose and what to give patients if they are deficient in any of those. So this slide here shows the impact of the nutrients briefly. So for example, vitamin A and C, along with the trace elements selenium and copper, they have anti-inflammatory effect and antioxidant effect for vitamin A, C, and E. Vitamin E, iron, and zinc are responsible for the immune function. And we've got vitamins A, C, and D are pretty good at protecting against respiratory infection. So overall, there are some potential benefits of those nutrients on COVID-19, and those are mainly decreasing the disease severity and hospital stay and increasing the recovery and the clinical outcomes. However, there hasn't been major studies about studying specifically effect of any of those vitamins or trace elements individually on a specific outcome of the COVID-19. Hence, those are still potential benefits, and I think it is just important to measure the levels, or to basically check the levels of vitamins and trace elements. If patient is deficient, we can go ahead and supplement them with more vitamins and trace elements. Otherwise, patients should be fine if their lab values are within the normal range. So all of this is when patient is intubated and requiring nutrition support, whether enteral or parenteral. However, as their clinical status improves and they get to be extubated, there is still a role that we can play in that nutritional support focuses on is basically the recovery and the rehabilitation. And nutritional management should be continued until the patient can resume oral intake and have sufficient oral intake on their own without any other nutritional support. So the main things that we look at after or post-extubation are dysphagia or tracheostomy or any swallowing disorder. So for example, if a patient ends up having some dysphagia, it is good to work closely with the speech therapists to guide us to know which kind of texture of the diet, dysphagia level 1 or 2 or 3, whether it's pureed or an easy to chew diet that the patient should be on. We should monitor their PO intake or their oral intake and make sure they're meeting at least 70% of their needs. If a patient ends up being on a tracheostomy, then it is also important to monitor their oral intake, and it's good to supplement them with oral nutritional supplement to help them meet their caloric requirements. If they can meet them only with oral nutrition and oral supplements, then that's good. If not, it is good to consider supplemental nutrition, which in most of the times can be through the form of enteral or tube feeding. If there's swallowing disorder and patient has a swallowing difficulty, there's a very high risk of pneumonia. So it's also good to work closely with SLP or speech therapist to help us know if the patient is safe to eat orally. If yes, then also it's good to know what kind of texture they can be on. If they have to be kept NPO, then we should consider enteral feeding, mainly nasogastric. If there's still aspiration, this is when we can consider post-pyloric feeds or a nasojejunal tube. And if also tube feeding is not tolerated, this is when PN can be suggested. It's also essential to have an idea about whether the patient will require a short-term nutrition support. So we can just insert a nasogastric or nasojejunal tube. However, if the patient requires a longer nutrition support term, then maybe a PEG or a PEG can be considered. So physical activity and its importance, definitely we all know that this promotes the preservation of muscle mass and mainly the lean body mass. So after the patient is clinically improved, the mobilization at bedside is encouraged and mainly to preserve their lean body mass. In the context of the limited availability and the access by the physiotherapist for priority of respiratory care, it will be adapted to the patient's capacity for autonomy, so they can try and do this by themselves and try to ambulate as much as possible, at least at bedside. And mobilization will be definitely intensified, and physiotherapists will work closely as the clinical improvement allows. So after discussing all of the recommendations of ASPEN and all the international guidelines in terms of nutrition support and when to give it, how to give it, enteral and parenteral nutrition, and even oral nutrition support, it is good to follow those recommendations, of course, but practically we've noticed when we covered those patients in the ICU that there are so many challenges in following those recommendations. And I thought it would be good to share them with you. One of them would be the high propofol dose. And you might be wondering how come this is a challenge. So if a patient is on high propofol dose for an X number of days in the ICU, that prevents us from increasing their tube feeding volume, because we cannot overfeed them and we cannot exceed their nutritional needs. So if we want to provide them with a higher volume plus the calories coming from propofol, that would lead to overfeeding. And sometimes even our protein provision is not adequate because of the high dose of calories that's coming from propofol. The intubation status of the patient, in the sense of, again, they're not conscious, they're not oriented, so it would be hard to have a decent communication with them to obtain all the dietary history or the weight history we want, which leads to an underdiagnosis of malnutrition. GI concerns, sometimes patients tend to have diarrhea on and off, vomiting on and off. So we will have to hold the feeds for a day and then restart it the second day at a low volume. And then if another GI concerns take place, we will also have to temporarily reduce or stop the feeds. So sometimes we have patients who, when we calculate their average energy or protein intake over a period of a week or two, we notice that they are being overfed because of the interrupted feeds, given the GI concerns that they have. And as previously mentioned, fluid restriction, if they have pulmonary edema or renal or cardiac failure, this also leads to fluid restriction, which sometimes might affect our need to meet their protein needs with a semi-concentrated feeding formula. So just as a conclusion, the main key takeaways of this presentation were just enteral over parenteral nutrition as recommended, even if patient is in a prone position or on ECMO or even on any kind of dialysis support. So it is always recommended to go with enteral nutrition first over parenteral nutrition. And as you notice, this is no different than any other non-COVID ICU patient. It's very important to start enteral nutrition early and progress the dose slowly to meet the goal within first week of ICU. Provide the patient with 15 to 20 kcal per kilogram of actual body weight or 1.2 to 2 grams of proteins over the first week of ICU. In terms of regimen type, continuous is always preferred over bolus feeds. We prefer nasogastric as opposed to nasojejunal. And it is recommended to place the nasogastric at bedside at the same time of intubation. Go with a semi-concentrated feeding formula, which is a 1.5 even to 2 kcal per ml feeding formula. Do not check for GRV as it's not a reliable detection of delayed gastric emptying. It is important to monitor for refeeding syndrome and monitor electrolytes and replete as needed. If patient is hemodynamically unstable, it is recommended to halt the enteral feeds. There is a low threshold to convert to parenteral nutrition. And as discussed, fish oil is of more benefit and importance than soybean lipid emulsion. So we should consider that when we provide patients with the lipid emulsion, and definitely cluster care, which makes the management of the COVID-19 patients very specific by following the cluster care guideline. So with this, we come to the end of the presentation. I hope this was informative and helpful to you guys. I think we'll be having a Q&A session in a little bit, so I'll be happy to answer most of your questions.
Thank you so much, Ms. Carla, for that wonderful presentation. But before we proceed with the Q&A or questions from our attendees, we are happy to present with you our sponsor for today's webinar, which is from Specialized Beauty on behalf of InBody Machine. We have with us Mr. David Wong, the team leader of InBody for Middle East and Africa. Mr. David, welcome to the webinar.
Okay, thank you, Ms. Carla, for the presentation, and it was so impressive and informative. So I'm David from InBody Company in South Korea, and I'm a manager of Middle East and African country for the InBody. So I'm so glad to see you all today, and thank you for providing this great opportunity to introduce myself. Okay, let me start my presentation. Today, I've come with InBody S10. So most of you are familiar with what InBody is, but you may not be familiar with this product. So this is specialized design for body water analysis and lying position measurement. So as you can see above pictures, due to availability of measuring lying position, InBody S10 is widely used in various medical departments where the patient who needs special care, such as dialysis unit, oncology patient, amputee patient, and so on. And especially in intensive care unit, the severity and nutritional status can be evaluated by InBody S10, even for COVID-19 infected patient. Then why do we need to use InBody S10 in intensive care unit, and how can we use it? First of all, as you know that malnutrition is highly prevalent in critically ill patients and is associated with the increased healthcare related costs and poor patient outcomes. And this research studies revealed that the majority of nutritionally high-risk patients fail to receive adequate calories and subsequently develop malnutrition. So here, out of 150 patients, about 80 patients were reported that they were in nutritionally high risk, and about 91.5% were underfeeding calories with development of malnutrition. So it is quite important to provide adequate calories with regular monitoring nutrition status which InBody S10 can help. Here we have InBody result, and I would like to show InBody protocol for ICU patient as shown right side. So we have 4 steps to use InBody S10 in intensive care unit. The first step is to check the severity of the patient. For serious situations that are directly related to the mortality, nutritional evaluation or calculation of total energy expenditure are not important. The first priority is to understand what the patient condition is and whether it can get better or not to survive them. So phase angle is a good tool to check the severity of the patient. And then the second step is to check the water balance by extracellular water ratio. So after checking the severity of patient, we can check water balance of patient. And there are 2 aspects of using this parameter. The first, extracellular water ratio itself can be used as meaningful data from a nutritional point of view. And second, the total energy expenditure calculation will have different approach or method according to the extracellular water ratio. And then we can calculate the total energy expenditure of the patient. And the last, we can evaluate the nutritional status with the skeletal muscle mass, body cell mass, and other parameters. First, severity check by phase angle. So this is the parameter directly related to cell membrane integrity or cell size. So it shows the phase difference between the voltage applied to the impedance and the current driven through it. So there will be time delay between voltage and current when they penetrate the cell membrane, and it is expressed as an angle. So higher phase angle indicates higher cellular integrity level, which also means low phase angle indicates poor cellular nutrition. And this is the one of study showing the accuracy of phase angle for critically ill patient. And if you see the graph on the right side, there are the area below the line shows the sensitivity of patient's mortality and morbidity of each indexes. And as you can see, since phase angle has the largest area, phase angle was revealed as more powerful predictor of mortality and morbidity of patients compared to conventional indexes to evaluate the severity of clinically ill patients such as SAPS, SOFA, APECHA-3. So it also shows that, as you can see the table below, phase angle shows the significant difference between survivors and non-survivors in the left side. So back to InBody protocol, phase angle, the cutoff value for ICU patient is 3.5. So when the phase angle is below 3.5, we consider the patient is in severe condition and need intensive nutritional care. But if the phase angle is over 3.5, we can go for the next step. So if phase angle is more than 3.5, then second step will be checking water balance by extracellular water ratio. As you may already know that around 50 to 70% of our body is made up of water, and the body water can be divided into intracellular water and extracellular water. So intracellular water is the water that is in the cell, and extracellular water is the water that is outside the cell. The normal people have constant ratio between intracellular water and extracellular water, which is 62 to 38. So when this ratio is broken or imbalanced, we say that this is edema. And this refers to the state when a person has some abnormal water retention in extracellular water. So depends on the extracellular water ratio, we have different approaches to calculate the total energy expenditure. So when ECW ratio is within normal, you can directly check the BMR in the result to calculate the total energy expenditure. But in case that extracellular water ratio is more than normal, we need to consider intracellular water as well. So if the intracellular water is under normal range, again, you can check the BMR to find out the TE. However, in case that intracellular water is more than normal range, then we need to separately calculate ideal fat-free mass to get the right total energy expenditure of the patient. And this is because that BMR in InBody uses Cunningham equation, which takes fat-free mass into the consideration. In other words, fat-free mass is overly estimated when there is a water retention, which results the overly estimated BMR as well. So that is why we need ideal fat-free mass to calculate the right total energy expenditure. And this is how to calculate ideal fat-free mass, but I will just skip today since we have limited time. So whoever would like to know more about it, kindly contact our team so that we can share you the more information. So after calculating the ideal fat-free mass, we will calculate the basal metabolic rate. As I mentioned that we use Cunningham equation to find out BMR. So the BMR can be calculated by multiplying 21.6 from the ideal fat-free mass and then adding 370. So either the ECW ratio is in normal range or higher, which is edema condition, you can get BMR, then calculate the total energy expenditure. So we use two different factors to calculate total energy expenditure, which are activity factor and stress factor. So since we are talking about the critically ill patient, we will have two different activity factor. One is whether the patient can walk or patient cannot walk or move. And then stress factors will be considered based on the certain condition provided in the screen. So with this information, we can calculate total energy expenditure of the patient. And for your information, I would like to share one interesting study. And this study investigated the usefulness of predictive equation for RE, resting energy expenditure, with the result of indirect calorimetry. So to calculate the Cunningham equation, as you can see in the table, fat-free mass is needed, so they use in-body S10 to find out the fat-free mass. And if you see the graph on the right side, the correlation is quite high, and the standard deviation was less than 200 calories. So you can see that the Cunningham equation is the second best among those equations. And what we also noticed here is that Cunningham equation tend to have overestimate the RE when we compare to the indirect calorimetry. And if we take a look at the raw data, patient profiles, we could find that the most of patients had the high ECW ratio, which is in edema condition. And if we remember our protocol, in case of edema, we need to calculate ideal fat-free mass to find out the right BMR, which have not been done in this research studies. So that is why the result apart from the Cunningham equations tend to have overestimated value than the indirect calorimetry. So if the result was based on the ideal fat-free mass, definitely two results will have higher correlation. And the last step will be monitoring nutritional status. As you know that InBody has lots of parameters like skeletal muscle mass, body cell mass, segment information, which you can refer to evaluate the nutritional status of the patient. And this research shows that evaluation of nutritional status can be performed by phase angle, extracellular water ratio, and other information. And those are more effective than other variables like BMI, albumin, TLC, and so on. So to sum up, as I mentioned, that there are 4 steps to use InBody for ICU patient. First one is to check the severity with phase angle. So in case of lower than 3.5 phase angle, the patient required to have intensive nutritional care to survive. And if it's more than 3.5, then we can go to the next step. We will check the water balance. First, to check nutritional status. Second, to have the right BMR. And then we will calculate the total energy expenditure of the patient. Then last, we can monitor the nutritional status with other parameters. So we have actual case showing how body composition changes after the recovery from the COVID-19. So we have several InBody results in different phases of COVID-19, like before, after, and during the recovery phases. And you can see more information and what did he do to improve his body composition back to normal, and how did he feel about his body condition with the change of body composition on our website, or you can contact our team. That's it. Thank you so much for listening my presentation, and I hope my presentation will be informative and helpful for you.
Thank you so much, Mr. David. I hope you can stay with us for quite a while because we have some questions related with InBody.
Okay. Just one thing I missed. Okay. Okay, I'm sorry that we are providing the free demonstration, and we have our exclusive team in UA, who is engineer Jishan Ali. So whoever wanna conduct the demonstration for InBody S10, please contact our team in UA, and the demonstration request during this webinar, we will provide all the interpretation of the result sheet from InBody headquarters clinical team. That's it.
Thank you so much, Mr. David. And for any attendees who would like to speak with Mr. Sashan, you can also go directly to me and I can provide the contact of Mr. Sashan for the pre-demonstration of the InBody machine. For the question, Mr. David, one of the question is, can we use mid-arm circumference to assess muscle mass as we don't have the sophisticated instrument mentioned to check the muscle mass?
Okay, in my opinion, that like people have different types of the body or the distribution of muscle mass and fat mass. So the having information of the arm circumference will not be enough for measuring the skeletal muscle mass. Instead, you can use the body composition analyzer to have the more accurate analysis for the skeletal muscle mass for the patient.
Thank you, Mr. David. Another question. What BMR reflect, food or exercise?
May I have your question again?
What BMR reflects? Is it food or exercise?
Okay, BMR is, as you know, that basal metabolic rate. Okay, so we calculate the total energy expenditure from the basal BMR, and we take both of activity factor and stress factor into the consideration to give the exact TE for the patient.
All right. One more question, Mr. David, and I'm not sure if you'll be happy to answer it live, but you can also share it with me so I can share with them. What is the price of InBody machine?
Okay, I think this information will be shared by engineer Jishan one by one, so he can contact our team, and we will give the price for the machine.
All right, thank you so much, Mr. David, and please stay with us. And I would like to move with Miss Carla. Miss Carla. Miss Carla.
Kim, I can hear you.
All right. So we have some few questions you would like to address. First question is, what are the examples of weight-based equations that can ideally be used for COVID-19 patients?
So ideally, we go with the Penn State formula, or the easiest way would be using the quick method, which is the 15 to 20 kcal per kilogram. So as I mentioned, Aspen and Aspen recommend the use of 15 to 20 kcal per kilo for all COVID-19 patients. Unless they're obese, we would go with 11 to 14 kcal per actual body weight.
Thank you. What is the name of the condition? Acute what? I think it's one of the examples that you use on your presentation.
I'm not sure if they're referring to the acute respiratory distress syndrome, unless it's a different condition, but I think that's the one with that starts with an A. So I think that's the acute respiratory distress syndrome.
All right, thank you. Lots of COVID patient is having drug-induced diabetes due to steroid treatment. How can we care for them, especially proper calculation of caloric intake and proper and accurate weight determination is impossible?
So yes, so accurate weight is not the best among patients with COVID-19. Again, given the fact that we cannot get proper history from the patient or family members. However, to estimate their dry weight, or if we have a history on the system, we can kind of get a sort of more or less of an accurate weight of the patient. But for them to be on steroids and diabetes induced by steroids, this would pose a concern on the blood sugar levels. So they would have elevated blood sugar levels, but that would not really affect us from the point of view of providing them with the number of calories needed. So the only thing that we should worry about when a patient is on steroids and have high blood sugar levels is to make sure we're not giving the patient a feeding formula that is high in carbohydrate. So we can choose a feeding formula that's controlled in carbs and mainly sugar, or even higher in fiber than other formulas to help regulate blood sugar levels. But the first line of management would be definitely insulin, and that's the pharmacist or the physician's decision to provide the patient with the proper insulin regimen.
All right, thank you. Is supplemental vitamin D recommended for COVID patients? If it is, what dose is recommended?
So as I mentioned in the presentation, vitamins are essential to give patients, especially with COVID-19. However, if the patient is not deficient with vitamin D, so after we check their baseline vitamin levels, and it is recommended to keep checking them every 3 weeks, especially after ICU admission. If they are within normal range, then there's no need to supplement the patient with vitamin D. However, if they are deficient in vitamin D, we do recommend 10,000 international units of vitamin D for the first 2 weeks after admission, and then followed by 5,000 international units until their levels get to 40 to 60 nanograms per milliliters.
Right. The next question, the table of nutrients doses recommendations is for patients who are on IV or as an oral supplementation?
No, those are oral supplementation. So definitely this requires that the patient is not intubated. For IV recommendations, they're different, but that's usually the pharmacist's decision to provide the patient with the specific amount of vitamins and trace elements.
All right, next question. Why is ferritin levels high in COVID patients?
Sorry, what is it? The ferritin levels?
Yes.
So, so ferritin is usually is a key mediator of the immune dysregulation, and especially if we have hyperferritinemia, mainly via a direct immune suppressive and a pro-inflammatory effects, which contribute to the cytokine storm. And because patients with COVID-19, as explained in the presentation, are at risk of the hyperinflammation syndrome, and they've got the cytokine plasma levels high, so the ferritin levels correlate with the severity of the cytokine storm. So it is expected to have high ferritin levels among COVID-19 patients.
All right, next question. Do obese people have higher BMR because of the organs which needs to work more?
Well, more or less, it's basically to accommodate for the extra fat they have and for their body to work harder, basically to perform the normal body function. This is why they have a higher BMR than non-obese patients.
Right. Next question. What is the best formula we can give to ICU patients?
So the best formula?
Yes.
As in feeding formula, or the formula to calculate the needs? Is it specified or?
No, it's not specified.
I think this is referring to the feeding formula. If it's the case, then as I mentioned, it is polymeric formula, mainly fiber-free. If patient does not have any GI concerns, then he can be on a standard polymeric, concentrated 1.5 to 2 kcal/ml. And it's a matter of monitoring other clinical factors. So if they've got high blood sugar levels, we tend to use the Nutrizon Diazon HP because it's controlled in carbohydrate. If they have renal failure or on dialysis, then they should be on Nepro, which is a renal friendly formula. So it actually depends on the clinical condition of the patient.
All right, last two questions, Ms. Carla.
Mm-hmm.
What indicators to use to assess malnutrition in COVID ICU patients?
So this is the indicators of the GLIM criteria, the Global Leadership Initiative on Malnutrition. So the indicators are, as mentioned, the phenotypic or the etiologic criteria. So we need to look at the BMI of the patient, if it's below 18.5 for someone who's more than 70 years old, if they have severe muscle deficit, or if they've got more than 10% weight loss in 6 months, plus the inflammation state that they're in. Those factors combined together would allow us to diagnose the patient with malnutrition.
Okay, last question from Ms. Janani. What are the recommendations for post-COVID malnutrition, especially in diabetes patients?
Recommendations for what?
Post-COVID malnutrition.
Yeah, so I'm not sure. Yeah, it is post-COVID malnutrition, but I'm not sure if it's a nutrition. Recommendations in terms of what to provide the patient with nutritionally. If it's the case, it's basically it's in the state where they are post-extubation. So we should make sure that they are getting sufficient oral intake through oral food, or provide them with oral nutritional supplements. If they can meet at least 70% of those needs by combining oral nutrition plus ONS, then that's enough. If not, we will still consider nutrition support in that case. If they're diabetic, then it's just mainly putting them on a carb-controlled diet and providing them with carb-controlled oral supplements.
All right, thank you so much, Ms. Carla, for the wonderful presentation. And we had a good comments from our participants that it was enjoyable and very informative one. Indeed, it was always an honor to work with you to providing such a good topic with our participants during this COVID era. Do you have any additional information, or you would like to say anything to our audience?
Thank you, Kim. It was my pleasure to be with you and to provide participants with this informative session. I hope they found it helpful. And thank you, everyone, for tuning in and for registering in tonight's session.
Thank you so much, Ms. Carla. And once again, to our attendees, thank you so much for staying this late with us. Thank you so much for attending our course together with Ms. Carla and sponsored by Specialized Beauty InBody Machine. For any questions related to the machine, InBody, or Specialized Beauty, please communicate with me. And if you wanted to be in touch with Mr. Zashan or Mr. David Wong, I can also share with you all their contact information. Once again, to all attendees, please be reminded that your CME certificate, especially for those staying in UAE, you can get your participation attendance certificate through the TAM portal. Some of you know about the process, but for those who doesn't know, please stay tuned for the email that Zoom will be communicating with you tomorrow. It will have the link of our PDF file with the step-by-step process of how you will create your TAM account and how you will request the certificate from DOH and how you will download your certificate. And for you as well, Ms. Carla, I hope you are also aware of the new process. You can get your certificate through the TAM portal itself. For any questions, you can communicate with me through our contact details. And for any upcoming events, you can follow us on our Facebook account, Instagram, Twitter account. And also the webinar for today is live streamed through our YouTube account and Facebook account. Once again, everyone, we wish you stay safe, and we hope to see you again soon in our upcoming webinars. And hopefully by next year in 2022, we'll be happy to see you in person. Stay safe, everyone, and have a nice evening.